So I'd like just to start by talking about the liver. It is indeed our hardest working organ, has over 500 functions. The main functions being, or two of the main functions being to clean and filter our blood, help with digestion. The liver regulates most chemicals that our body comes into contact with, even through our skin. The liver excretes bile, which helps to carry waste products away from our liver, and all the blood leaving the stomach and intestines passes through our liver. The liver processes this blood and metabolizes fats, drugs, alcohol, and other toxins. Our liver is really important for our immunity by making immune factors and removing bacteria from the bloodstream. Helps regulate energy by converting carbohydrates into glucose for available energy, is important for regulating our hormones, produces blood clotting agents and stores vitamins and minerals for later use, and produces cholesterol as well and stores iron. So an incredibly hardworking organ that deserves to be cared for. Okay, just like to talk now, thanks Clive, that's been a nuisance, isn't it? Talk about liver disease, a brief overview. And just to say that, and I do acknowledge that some people here will know a lot more about the liver disease and viral hepatitis than me, and maybe some will appreciate a bit of an introduction. So in terms of our liver, just like to mention that our liver can continue functioning over a long period without showing specific symptoms or signs of damage. And in fact, some symptoms of liver disease go unnoticed for years, and for some people it may even be 20 years or so. Some people do experience symptoms when they contract infection, and some of the symptoms can be very easily confused with other symptoms from a lot of ailments that we get, such as feeling unwell, tired, tenderness or pain in the liver. Some people experience itchiness, but not everybody. Swelling of ankles, jaundice, unusual or persistent darkening of urine, and some people describe brain fog. Not everyone experiences these symptoms, and some of them, as mentioned, can be confused or relate to a whole range of other ailments. So in terms of who is at risk of liver disease, people who are overweight or obese, people who drink a lot of alcohol, and in fact it doesn't really need to be too much alcohol. People who do have hepatitis B or C are at significant risk of liver disease unless they have treatment or care. People who have a problem with their immune system, that's quite, well, people born with liver disease, that's quite a rare condition. So in terms of liver disorders, fatty liver disease includes alcohol-related liver disease, or otherwise known as ARLD. And fatty liver disease takes place where fat accumulates in the liver, inside liver cells. It can gradually damage the organ and lead to serious complications such as hepatitis, cirrhosis, and even liver cancer or failure for some people. The fat may come from other parts of the body, or the liver may absorb an increased amount of fat from the intestine, or the liver may lose its ability to change fat into a form that can be eliminated. So again, fatty liver disease may go unnoticed for many years, which is a problem for a lot of disorders of the liver. So alcohol-related fatty liver disease, ARLD, form of fatty liver disease that occurs when the liver is affected by excessive drinking of alcohol, and alcohol-related liver disease is diagnosed. If alcohol-related liver disease is diagnosed early, it can be effectively managed, particularly when people cut down on their drinking or eliminate drinking. So I think that's a really useful message for people. Non-alcoholic fatty liver disease, NAFLD, is the most common form of fatty liver disease. And I think a lot of people would assume that fatty liver disease, the most common form would be ARLD, but that's not the case. NAFLD is an umbrella term that covers the simple accumulation of fat in the liver cells, which sometimes progresses to swelling, fibrosis, and cirrhosis. And risk factors include a high diet in carbohydrates, sugar, fat, and processed foods. And this can also be managed by working on a safe and healthy lifestyle plan. Non-alcoholic steatohepatitis, or NASH, occurs when the liver becomes inflamed in the advanced stages of NAFLD and is associated with obesity, diabetes, and all the elements of metabolic syndrome. Viral hepatitis is inflammation caused by viruses. Hepatitis really just means inflammation of the liver, and we'll discuss that at length later today. Liver cirrhosis, if our liver is damaged and left untreated, over time it can lead to cirrhosis, and damage begins when healthy cells become inflamed or swollen. If the inflammation is left untreated, some cells die, making the liver lumpy, scarred, and making it really difficult for the liver to do its job. The liver becomes stiff. At the cirrhotic stage, it becomes quite hard and lumpy, so blood is not able to flow through. Without proper blood flow, the liver can't function properly. And at that point, symptoms include abdominal pain, vomiting blood, bloody stools, nausea, and water retention and appetite loss. So pretty severe symptoms by that point. There is a higher risk of liver cancer for people who have hepatitis B, hepatitis C, fatty liver disease, and liver cirrhosis from any cause. This may lead to liver failure or stressed liver functioning, and extreme cases of cirrhosis and cancer will eventually warrant a liver transplant. I think it's useful to say that not everyone who has the liver disease will develop liver cirrhosis, and not everyone who has liver cirrhosis will develop liver cancer. Genetic and autoimmune diseases are inherited forms of the disease that can cause the liver to undergo metabolic abnormalities, and autoimmune disease causes damage resulting from an abnormal immune response to liver cells. But most of these conditions are rare. Okay, so moving to the global and Australian context, there are really significant numbers of people globally who die from viral hepatitis every year, and quite significant numbers of people in Australia too who are living with hepatitis B and hepatitis C, as we can see from those figures. And I think it's interesting to note that globally, far more people die every year from viral hepatitis than they do from HIV-related causes or from malaria. So in 2020, for example, around 680,000 people died from HIV-related causes, and around 627,000 people died from malaria. So we tend to hear quite a lot about malaria and HIV, and tend to hear less about viral hepatitis, despite the fact that it's such a significant issue around the world. Just to note too that during the pandemic, or during 2020, there was a significant drop in the number of people who received hepatitis screening compared to the expected number, so around 20%. So that's somewhat of a concern. Okay. I think we've already mentioned the causes of hepatitis, or inflammation of the liver. In terms of viral infection, which we'll focus on more, just like to note that hepatitis D only co-occurs with hepatitis B. And it can occur as a superinfection in people who have chronic hepatitis B, but it's not common in Australia. Hepatitis E is also not common in Australia. It's found in Southeast Asia, North and West Africa and Mexico. And the route of transmission for hepatitis E is the fecal to oral route, same route as for hepatitis A. But unlike hepatitis A, there's no vaccine for hepatitis E. Okay, as noted in this slide and noted previously, for many people, viral hepatitis is asymptomatic. A lot of people won't know that they have it and may not feel the effects for many, many years, even decades before serious health implications take place. So one of our key messages is if anyone has ever been exposed or think they may have ever been exposed to hepatitis, that they go and get tested. So we'll talk a little bit more about that too. All right. Hepatitis B has been around in the world for a long, long time. And I think it's quite astounding that around a third of the world's population has been infected at one point in their lives, which seems incredible. In terms of the acute phase of hepatitis B can last for up to 6 months. During that phase, people are able to transmit the disease to other people. For some people, they will spontaneously clear the hepatitis B virus, and the likelihood of that really depends on the age of the person when they contract the virus. For adults, around 90% or 95% of people will spontaneously get rid of the virus within that 6-month period, that acute phase. However, babies have a very low chance of clearing the virus, and even as low as 1%, so between 1 and 5% may clear the virus, which means that around 95% will go on to live with chronic hepatitis B unless there's medical intervention shortly after birth. So for people who do not clear the virus within that 6-month period, they will go on to have chronic hepatitis B, which is a lifelong condition. In terms of stages of progression, as mentioned before, it can take 20 years or so for serious damage to take place. Damage starts off with scar tissue developing, having been killed off by inflammation, leading to fibrosis. And with treatment, fibrosis can heal. So in those early stages, treatment is really useful and also reinforces the message for people to go and get tested if they think they may have been exposed to the virus. Further damage takes place where mild to moderate fibrosis has or develops walls of scarring and then progresses to fibrosis that has spread to other parts of the liver. The cirrhosis stage or cirrhotic stage is where the liver is full of hard, scarred tissue, and it makes it difficult for the liver to function. Treatment's still beneficial at that point, and damage can progress for some people to liver cancer. End-stage liver disease is where the damage can't be reversed. However, a liver transplant is maybe an option for people. So as mentioned before, not everyone who develops cirrhosis will develop liver cancer. Not everyone who develops fibrosis will develop cirrhosis. So there's some good news amongst the less good news there. In terms of at-risk populations, as you can see from this graph, at-risk populations include people born in Northeast Asia, Southeast Asia, in Australia too. Aboriginal and Torres Strait Islander people make up about 7.2% of people who contract hepatitis B. other groups here, people who inject drugs, people born in other regions that we don't necessarily know about, people born in North Africa and the Middle East, Sub-Saharan Africa, and people born in Oceania, including Australia. People at risk include infants and children born to mothers who have hepatitis B. They're at extremely high risk of contracting the virus unless they receive vaccination or a dose of immunoglobulin shortly after birth in the first of their 4 vaccinations. It's absolutely vital that infants are offered those as soon as possible after birth. People with multiple sexual partners, sexual household and family contact with people living with hepatitis B, sex workers, health professionals who perform exposure-prone procedures, people in custodial settings or who have ever been in a custodial setting are at risk of hepatitis B, high-risk groups, hemodialysis patients, and people living with hepatitis C and HIV. People who had blood transfusions prior to 1990 in Australia were at risk, and people who have blood transfusions or unsterile medical procedures in overseas countries continue to be at risk. And it's a pretty wide kind of group, but pretty much everyone who has not received their hepatitis B vaccinations and are thus not immune are at risk. Here we can see that, how many people in Australia are affected by hepatitis B, and concerningly, more than 70% living with chronic hepatitis B are not receiving care. It's recommended that all people who contract hepatitis B receive care. Some will require treatment, not all, but everyone needs to have regular checks with their doctor. So only about 10% are receiving treatment, despite 20% estimated to need treatment. Wonder if anyone can suggest why that might be. It's very noisy next door. Would anyone like to suggest perhaps some of the factors that might lead to people not receiving treatment? Sure. Yeah, I think that's a really good point. Access and language barriers may be a factor for some people. Okay. Any other suggestions?
The stigma involved in seeking treatment.
Yeah, I think that's a really good one too, Stephen. And people perhaps fearing stigma as well, or fearing judgment if they reach out to seek treatment. Yep. Okay. And for some people, it may not be a priority, depending on what's going on in their life, where there are a lot of things going on, a lot of stresses or a lot of change taking place in their lives, lack of resources perhaps, and socioeconomic status may be a factor, either real or perceived. Okay. How am I going for time? Okay. Good. All right. So this slide has been developed and particularly for the Western Victoria Primary Health Network. The data has been drawn from the Viral Hepatitis Mapping Project undertaken by the Dufty Institute in association with World Health Organization and ASHM. So we can see that there's been approximately a 5% treatment uptake in the Western Victoria PHN, and around 6% in Geelong for people living with chronic hepatitis B. Western Victorian PHN has a lower prevalence of hepatitis B compared to the national average, but it still has low rates of care, and from the graph, less than 12%, and treatment uptake is in comparison to higher prevalence PHN. So that's something to be mindful of. Yep. What does it mean? In terms of care, what is meant for care for people with hepatitis B is people having regular checks with their doctor to track their liver condition and their viral load. Not everyone requires treatment for hepatitis B, but situations can change for people, or their condition of their liver can change. So they may not need treatment, this year or in this half of the year, but depending on the level of virus and what is happening there, they may need to go on to treatment later in the year. So care really just means very regular checks. So 6-monthly appointments are recommended, whereas treatment, which is available to people should they require it, helps suppress the viral load, but only if they need to. Otherwise, people's own immune systems may be, keeping that viral load down. Okay, thank you. We'll go on to transmission now. So hepatitis B is a blood-borne virus, the means of transmission being through the blood of a person who has hepatitis B entering the bloodstream of another person. Can also be transmitted through exchange of sexual fluids, where the fluids enter the blood, where there is tearing, for example, or an STI present. The risk of infection is higher through unprotected sex, or mother to baby. So testing and monitoring of pregnant women is routine in Australia. Has been for quite some years now, and pregnant women are usually screened for hepatitis B at their first antenatal visit. Just to mention that hepatitis B can survive outside the body for around 7 days, approximately. So we'll talk a little bit more about the vaccination in a minute, but we'll just go on now to hepatitis B testing. So there are 3 tests taken to assess a person's hepatitis status, and it's really important that these take place, as they must do to confirm someone's hepatitis B status. So the first test tests for current infection, hepatitis B surface antigen. The hepatitis B core antibody tests for exposure to the hepatitis B virus, so will reveal whether someone has ever been exposed to the virus. And the hepatitis B surface antibody tests for immunity to the virus. And immunity may be through having been vaccinated or through having been exposed and spontaneously cleared the virus in that first 6-month period. Medicare covers testing once per year for people who are not on treatment and 4 times per year for people on treatment. So there's a little bit of a mismatch there in that People who have hepatitis B but are not on treatment will only have one test covered by Medicare in a 12-month period, even though it's recommended that they have 6 monthly testing. So the window period for hepatitis B is generally 30 to 60 days, being the time between infection with the virus and where it's detected in a blood test. So if someone thinks they may have very recently been exposed, they'd be advised to request a blood test after a month. Okay. All right. Importantly, vaccinations have been offered to all newborn babies, or they should be, since the year 2000. Sometimes babies miss out through one reason or another, but vaccinations are available to babies. It's really important that babies born to mothers who do have hepatitis B are offered immunoglobulin shortly after birth, within the first few hours after birth, and the first of their 4 vaccinations. Vaccinations are free for children and for everyone under 20 years of age, for refugees and asylum seekers regardless of Medicare status, and for Aboriginal and Torres Strait Islanders. Vaccines can be accessed through a doctor or sexual health clinic. And in Victoria, they're also available for household contacts and sexual partners of people living with hepatitis B, people who inject drugs or on opioid substitution therapy, people living with hepatitis C, men who have sex with men, people living with HIV, people no longer in a custodial setting, who commenced their course of vaccination while in custody, but who did not complete that course of vaccines. And people born in priority hepatitis B endemic countries who have arrived in Australia in the last 10 years. Countries including China, Philippines, Malaysia, Vietnam, Afghanistan, Thailand, South Korea, Myanmar, Indonesia, and Singapore. Immunity can wane over time for some people, and so people who are immunocompromised and people particularly living with HIV or who have renal failure may require a booster to keep the level of their immunity up. For most people, most people who complete a course of hepatitis B vaccinations will be protected for life. A test should be undertaken, though, after completion of the course, just to make sure that people are immune. Catch-up vaccines are available. Unfortunately, there's not yet a cure for hepatitis B. Hepatitis B can be managed in general practice. Not everyone needs treatment straight away, as mentioned, if their immune system is doing a good job of suppressing the virus. And for some, the virus can reactivate. So it's important for those checks to take place. In terms of medication, generally, people who need medication are people with signs of liver disease, people at risk of liver cancer, and people who have a family history of cirrhosis. Okay, another one of these slides about where the Western Primary Healthcare Network has been highlighted. And we can see that from the slide, the treatment uptake in Western Victoria is well below the national average. So treatment uptake for hepatitis B, that is, ranking 25th. And the National Hepatitis B Strategy target for treatment of hepatitis B was 20% by 2022. Nationally, it's sitting at 9.3% of people who have hepatitis B. So there's a lot of work to be done, a long way to go before that target can be reached. care uptake. Again, in Western Victoria, the rates of hepatitis B care are low, ranking 21 out of the national PHNs. I'll now hand over to Chloe, who's going to talk about hepatitis C.
Thank you. Alrighty. Hi, everybody. I'm Chloe. I get really excited talking about hepatitis C because particularly in the Western PHN, it is a bit of a good news story. So hepatitis C affects approximately 118,000 Australians, and more than 60% of them remain untreated. So that's the bad news part of it. Of those who are considered diagnosed, a quarter of them have not received testing to find out whether their hepatitis C is chronic. In Victoria, 40,000 people are living with chronic hepatitis C with a treatment uptake of approximately 55%. But we have a better news story in the Western Victoria PHN, and we're going to talk about that shortly. So in the Western Victorian PHN, more than 4,000 people are living with chronic hepatitis C, well below the average in Victoria and the national prevalence. Treatment uptake at the end of 2020 was highest in Western Victoria PHN at 65%. So that's fantastic. And all of you health workers out there are doing a fantastic job and deserve a congratulations for that. So well done. The only PHN in Australia to have already reached the 2022 national strategy target of 65% uptake was the Western Victoria PHN. If we focus on Geelong, we can see that more than 1,000 people are living with chronic hepatitis C with an excellent treatment uptake rate of 76%. So this graph tells a really good news story. So why does it matter? Like we've talked about in the previous slides, liver disease is a progressive disease, and hepatitis C is included in that progression. So we start off with your normal healthy liver, we move into chronic hepatitis where we're seeing things like fibrosis, then we move into cirrhosis, then we move into end-stage liver disease and potentially cancer and potentially the very sad story of death. Who's at risk of hepatitis C? People who inject drugs, people who have been in prison or have ever been in prison, newborns of hepatitis C positive mothers. However, this risk is reasonably low at about approximately 6%. People who receive blood product transfusions before 1990 or have done so overseas, medical procedures and blood transfusions overseas. That was in my notes. And people who have migrated from regions with high endemic rates of hepatitis C. Also, Aboriginal and Torres Strait Islander communities are overrepresented in the prevalence for hepatitis C as well. And that's something that we should all be working towards as healthcare workers to improve. So transmission routes of hepatitis C. It's a bloodborne virus. So one of the things that we're seeing emerging, particularly in young populations, is unsterile tattooing and piercings. You can pick up a tattoo gun on eBay for about $100, but you can't pick up an autoclave machine for that rate. So unfortunately, we are seeing an emerging trend of people having tattoo parties. Sharing injecting equipment, not just the needles, but the swabs, the tourniquets, the spoons, the water, all injecting equipment. Sharing snorting equipment because the nasal passages are particularly sensitive and can rupture. Sharing grooming items, so toothbrushes, razors, anything that can potentially be contaminated with blood. Workplace exposure, so healthcare workers working in exposure-prone procedures. And finally, mother to baby. But again, as I mentioned, the risk is particularly low with mother to baby unless there is an HIV co-infection. So just to make this a little bit more interactive, I'm going to get you to raise your hand if you think that hepatitis C can be transmitted by mosquitoes. Okay, good answer. What about by sharing food? Anybody? Holding hands? Oh, this is a good crowd. I'm not getting a lot of feedback, but it's good that I'm not getting a lot of feedback. Kissing and sharing saliva. Nope. What about using public toilets? And then finally, breastfeeding. Does anyone think that hepatitis C can be transmitted by breastfeeding? Excellent. The only caveat being is the mother has cracked nipples, there is the potential for transmission through blood through cracked nipples. So the transmission routes of hepatitis C are not any of these things. So we have a fantastic cancer prevention program called needle and syringe programs. The reason they're a cancer prevention program is because if we can prevent hepatitis C, we can prevent the progression of liver disease. And as far as I'm concerned, needle and syringe programs for people who inject drugs are a brilliant outlet. Also in the Barwon Health Community Health and Health Centres, there are several needle and syringe programs which are accessible to people who inject drugs. Education is one of the things that's most empowering. So you as healthcare workers are uniquely positioned to have these conversations with people about their hepatitis C status and encourage people to get tested, encourage people to get treated and get the cure. And then the universal precautions, treating every person as infectious. So that doesn't mean you treat everybody with stigma and discrimination. That means you treat everybody equally as though there is a potential risk of a bloodborne virus, but you don't single people with hepatitis C out. So testing and diagnosis, there are two tests that we need for hepatitis C. The first test being the antibody tests will confirm your exposure to the hepatitis C virus. If it's negative, that's fantastic news. No further tests are required unless you engage in risk-taking behaviour again. If it's positive, you need to do a hepatitis C, I'm going to say PCR, it's a polymerase chain reaction test. I want a round of applause for that. Thank you. Why don't we just do the second test to confirm if somebody has a current hepatitis C infection? The fact of the matter is it's an unfortunately quite expensive test and not always covered by Medicare. So it's estimated that 1 in 5 people living with chronic hepatitis C have not been diagnosed or are unaware of their infection. So as healthcare workers, that's a really big area to start having conversations with people. The antibody test is a simple blood test and the PCR test is a blood test as well. If you are shown to be positive, care pathways include an ultrasound, a FibroScan, which is a little bit like an ultrasound, and screening for liver scarring and stiffness. And you go into your pre-assessment to see what is necessary to access the cure and the pre-assessments. So hepatitis C in this respect is actually quite a good news story. What I want to talk about in the pre-assessment, we perform a virological evaluation to confirm the diagnosis of the infection, identify the genotype of the hepatitis C virus. So there's 6 types of the virus that people can be infected with. We want to document the hepatitis C treatment history and evaluate for the presence of cirrhosis or fibrosis. We also want to check for the presence of hepatitis B virus or HIV co-infection and consider whether coexisting liver diseases are present. So this is where we get into the good news bit. The old news was the interferon treatment, which people still think is available, and it's not, thank goodness, was a very harsh treatment. It was similar to chemotherapy, and it had some very harsh side effects. So people were inclined to suicidal tendencies, had major mental health implications, and it was just a very harsh treatment that wasn't as effective as it could be. The great news story, since 2016, we've got direct-acting antivirals. They are incredibly effective. They are more than 95% effective. They are subsidised on the Pharmaceutical Benefits Scheme, the PBS. And for people with a healthcare card, they come in at around $6.60 per month. For people without a healthcare card, they come in around $40 a month, roughly. For people without a Medicare card, the cost is significantly more significant, and I'm going to leave that discussion up to Dr. Amanda Wade to to touch on if she can. The treatment is with tablets, so there's no more injections, and it's a tablet a day over 8 to 12 months. And the commonly prescribed medications are Epclusa, Maverat, and Harvoni. So there are barriers and restrictions to treatment, and this is where healthcare workers can really make a difference again. Firstly, one of the things that I'd like everybody to advocate for is the Medicare availability to people who are Medicare ineligible, having discussions with your local MPs to make a difference there would be very, very powerful. There's also stigma and discrimination for hepatitis C, and I believe Dr. Farrugia is going to talk about the impact of stigma and discrimination in his presentation, so I'm not going to cover that in any great depth today. There are always competing priorities in healthcare settings. So particularly in AOD and mental health care settings, we want to get people treated for their injecting drug use. We want to get people treated for their mental health care, and those things tend to take priority over hepatitis C. However, you are all in a unique position to have these amazing conversations with people and encourage them to go get their blood test and know their status and move forward in their treatment if they need it. And then anyone can get the hepatitis C treatment. So it doesn't matter if you're using drugs, it doesn't matter if you're on a drinking program, it doesn't matter if you get reinfected, you can be cured again. And it's just a really good news story in terms of the availability of direct acting antivirals. So further to the good news stories, the Western Victoria PHN is doing particularly well in terms of treatment uptake. Only 4 of Australia's PHNs, and there's 31 of them, have actually achieved or are on track to meet the 2022 National Strategy target of 65% treatment uptake. Western Victoria PHN is one of them, which is fantastic, and you all deserve a congratulations for that, so well done. Unfortunately, the decline due to the lockdowns and pandemic has seen a steep decline in treatment uptake, and none of the PHNs are on track to meet the 2030 WHO elimination targets. However, with advocacy and conversations and treatment and getting active in the hepatitis C sphere of things, it is entirely possible to get back on track for those 2030 targets, I believe. And then finally, COVID-19. I hate talking about COVID-19 in an environment where we're all a bit COVID-19'd out. But some people living with COVID-19 have reported abnormal liver function and liver injury. Side effects include headaches, nausea, mental health implications. People who are currently using drugs also have negative side effects with COVID-19 and liver health. And it's important to encourage self-care, address lifestyle factors, so eating well, being drink aware and reducing or eliminating your alcohol intake, getting active. Who here has really struggled with getting active after the lockdowns? And yeah, it's been a thing. And feeling well, so looking after your mental health and accessing, if you have access to support, making sure that you build those networks of friendship and caring for yourself is really, really important. So to summarize, for hepatitis B and C, there are significant rates of viral hepatitis B and C in Australia. The Western Victoria PHN has a really good news story for hepatitis C, and a fair bit of work to be done for hepatitis B. Both hepatitis B and C have an acute phase and a chronic phase. So the acute phase is less than 6 months. The chronic phase is if you go on and have the disease for life. Hepatitis C, however, has a cure. And I can't emphasize that enough. It has a cure. There is an effective vaccine for hepatitis B, and there are effective antiviral treatments. Unfortunately, with Hep B, it's not like HIV, where undetectable means untransmissible. In terms of Hep B, undetectable doesn't mean untransmissible. So you're still infectious, even if your viral load is undetectable. And finally, there are effective cures for hepatitis C.